All right, so good evening once again. Erasmus Okello is my name. I am a moderator for this forum. This is the statewide Anesthesia and Critical Care Seminar brought to you by the Association of Anesthesiologists of Uganda and the Intensive Care State of Uganda, live on Zoom as well as on YouTube channel, with other recorded videos available there, and more information is available on a number of social media channels. Today, we are in for Pulmonary Madness once again, as it has been the case for our Fridays, running from 5 p.m. to 7 p.m. And today we will have quite a fun session going all the way back to Cradle. But first is what happened previously. Last Friday, we were here with quite a number of colleagues from other subspecialties who had joined us to discuss the cross-specialty diagnostic consultations that we make, especially in terms of pulmonary disease. So we had a clinical case presented by Dr. Maria. Dr. Paul Katongole took us through microbiology and specimen question analysis, followed by Dr. Juliet, who took us through chest imaging, particularly CT diagnostics. And then finally, Dr. Wenceslas Katajira took us through pulmonary endoscopy. So specifically focusing on performance and application of bronchoscopy in diagnosis and intervention against a number of medical conditions affecting breathing, the respiratory system. So that session is available, it's recorded, and really some of the big take homes is that there's a lot of pulmonary diagnostics that we probably don't use so well, and still amounts to abuse of diagnostics, the samples that we don't collect on time, or the specimens that we waste, and the fact that we start patients on antibiotics without really intervening, or pursuing diagnostics well. And the fact that sometimes when we get diagnosis, so we don't really adjust treatment. These are all things that we kind of will help to understand by the micro talk. And then really, whenever you have a patient who is sick enough to be in the ICU, perhaps getting a 3D image in terms of CT scanning really helps to paint a picture much better, to see all the angles beyond what a chest X-ray might show you. And we could see how what appears to be lines and dots on an X-ray would turn around to be something quite grave on a CT scan. Sometimes it is necessary to put in a camera into that airway so you can see the lung from the inside, see the airways, and that may be useful for collecting specimens for diagnosis as well as therapeutic purposes, depositing medications, sucking out material from the lung that can clear out the lungs and help the patient breathing. So today we are going back to where it all started. Certainly we're not going to fetus, not at this point, but we are going close to what a fetal life looks like. And in this particular case, we're looking at the neonatal lung. And together with us is a team of doctors who deal with children, and they're going to help us understand what it takes to take care of a child. So myself and Dr. Cornelius will be the moderators, as has been the case. And these guys are special in their own way, so there will be no mentor today. We are all here to learn. And so I'd like to invite you to this session officially by reading out the rules as usual. Make sure you're muted when you join. Do not unmute unnecessarily, and share your questions in the chat. Raise your hand when given a chance, and we'll have a fruitful session. So quickly, about the first presenter of the day, Dr. Winnie Nalwoza is a third-year resident in anesthesia critical care. She will be taking us through the clinical cases of the day, and then we will proceed with the real kick of the matter. So over to you, Dr. Winnie. I'm going to unshare, and you share your slides right away.
Good evening, everyone. You're most welcome for this week's session. And I'm Dr. Winnie, as I've been introduced. I'm going to take us through the clinical case for today's presentation. And you're going to get right into it. So I'm presenting a case of a neonate preterm, and this is a history. So we had a gravida 3+2+0 at 30 weeks of amenorrhea, who was post-COVID disease, and she had post-COVID lung sequela, and she had suffered the COVID about a year before. So she presented with at 30 weeks of gestation with severe preeclampsia, active viral pneumonia with moderate respiratory distress. The fetal heart rate was 80 at that point, and the baby was in distress. We had severe oligohydramnios, and the mother was stabilized briefly, and then emergency cesarean section was suctioned immediately. So when the cesarean section was done, we delivered a live female premature baby at 30 weeks of amenorrhea. We had a birth weight of 1.25 kilograms. Baby scored 4 at 1 minute, 5 at 5 minutes, and we had a score of 8 at 10 minutes. The meconium was grade 3, or as observed. Baby was immediately suctioned, mouth and nose stimulated, and we had bag and mask ventilation for about a minute or two. We initiated a bubble CPAP with FiO2 over 100 in theater, flow rate over 8 liters per minute, and this was given for about an hour. Reassessment was done. We had a respiratory rate of 80 at that point. SPO2 was 85. Silver Anderson score was 7 out of 10. Heart rate was 190 beats per minute. So baby was transferred to the NICU at this point. On arrival to NICU, we had a sick-looking baby in obvious respiratory distress. Baby was afebrile, and they had a heart rate of 182. Respiratory rate was 82. SPO2 was 75 on room air, and the temperature was 37.1 degrees Celsius. So water tachypneic and tachycardic. SPO2 was also down. So the respiratory system, we had shallow breathing, where transmitted sounds throughout the lungs and reduced air entry bilaterally. CVS, we had unremarkable findings. That is a normal heart sounds. Cup refill was less than 3 seconds. We had warm pink extremities. CNS, we had normal primitive reflexes and active spontaneous movements were observed. Musculoskeletal, we had reduced tone at this point. So blood was taken off for investigations, and later we found that the CBC was normal. CRP was elevated at 15. PCT was 1.8, still elevated for that day, first day. And the rest of the investigations were quite normal. Bilirubin, RFTs, and extended electrolytes were within normal ranges for age. So at this point, the most probable diagnosis was preterm, who had very low birth weight with RDS. We had meconium aspiration pneumonitis, and we're also querying probable sepsis, but also in view of the history and also the CRP and PCT, most likely we had sepsis at this point. So immediately the child was intubated with a size 2.5 ETT with a Miller plate 0. We observed thick copious meconium in the trachea while intubating, and also we suctioned out from the ETT as well. SPO2 improved all the way from 82 to 95%. We administered surfactant at this point. We gave 150 milligrams and removed the tube. We did a CPAP trial with a bubble CPAP, and we continued this for about an hour. At the end of the 1 hour, the SARS score improved from 7 to 5. Respiratory rate decreased to 75 as well. So at this point, we declared that the CPAP trial was successful, maintained the baby on CPAP. We put settings of flow rate of 8 liters per minute, a people 6, and the FiO2 of 60%. This is a picture of a bubble CPAP that you're talking about. Notably, it has oxygen blenders, has humidifier, and other parts. So the rest of the management plan included NICU protocol, as expected. Respiratory support was going to be continued with a CPAP, but notably, we pruned the baby for about 24 hours. Caffeine was administered at 25 milligrams loading dose IV and then maintained with 13 milligrams OD for about 3 days. Antibiotics were given, IV ampiclox and IV gentamicin. Ampiclox was given at 100 milligrams per kilo BD, while gentamicin was given at 4.8 milligrams per kilo OD. IV vitamin K was given 1.3 milligrams OD for 3 days, and also fluids and nutrition were given, as going to explain ahead. So this was a follow-up for the baby throughout the stay that were with us. So the child was just for about 18 days. And on day 1, CPAP was maintained on FiO2 of 60, titrating to be left, targeting SpO2 of 90 to 94, PEEP of 6, flow rate of 8. These were titrated as the baby kept improving up to day 3. So they maintained the same setting mostly for about 3 days. On day 4, baby had improved greatly. We had an FiO2 of 21%. PEEP had been reduced to 4 and was a flow rate of 5. So after day 5, the baby was weaned off CPAP onto room air. For the rest of the stay to day 18, the baby was on room air with no support, saturating very stably, and the respiratory rate was also normal. Caffeine was administered, as initially said. We gave 13 milligrams OD, and this was given for 14 days. And beyond 14 days, we switched it to oral, and it was administered for another 6 weeks. So to make a total of 2 months, because the child was preterm and risk of apnea. IV vitamin K was given at 1.3 milligrams for just 3 days OD. So on day 3, the child developed neonatal jaundice, and they were given phototherapy using red lights. It was given for about 4 days, that is day 3, day 4, day 5, and day 6. Beyond that, the baby stabilized and we didn't have any more jaundice. Antibiotics were given for 7 days, still maintained ampigenta, and beyond, on the 7th day, the septic markers had dropped. Baby had no symptoms of sepsis. That is the temperature and others, so were quite stable. They were weaned off on day 7. The feeding, on day 1, we gave IVD 10%. We began with 80 mils because it was a premature and they had respiratory distress. So we went to 80 mils on day 1. We increased to 100 mils day 2. On day 3, we introduced the neonatal cocktails and EBM. So we started with EBM of 24 mils while the cocktail was at 96. We gradually increased the EBM to 48 mils on day 4, and also increased the cocktail to 102 to make a total of 150 on day 5 days. However, between day 5 and day 8, we maintained the same EBM at 48 and the cocktail at 102 because the baby was not tolerating pills. So they had episodes of vomiting occasionally. So we opted to manage that with maintaining the feeds, and the baby picked up. On day 8, we started increasing the EBM from 48 to 72 while reducing the cocktail. So that at the end of day 10, all the feeds were being given through EBM, that is 150 mils per kilo per day, where the cocktail was taken off. Investigations were stable up to this point. Kangaroo mother care was started on day 9, and this was maintained up to discharge. Notably, this could have been started earlier, especially when we weaned off the CPAP, but the mother had surgical site sepsis, so we could not start it earlier, and there was no alternative person to help do the care, the kangaroo care. The father wasn't in the picture. So we started it on day 9. So between day 9 until discharge, that is day 18, our major focus was on the kangaroo care that was given PRN, aiming for about 20 hours a day, and also the weight gain of the baby. to discharge. So at discharge on day 18, baby was weighing 1.22 kilograms, and they were discharged home with nursing care. This was because we aimed to achieve a weight of 1.3. It wasn't achieved because of other factors, but the mother, we had financial issues. So we opted for home care, but with nursing at home. And this was emphasized, the importance was emphasized of follow-up. Her feeding was maintained for 6 weeks, oral, 13 milligrams. And kangaroo mother care was also still given PRN. EBM was being given at 18 meals hourly. This was because we had some regurgitation when we gave the 2 hourly feeds. So the baby could tolerate 18 meals at this point and was explained and given quite well. So the immunization was going to be started at when the child weighs 1.5 kilograms, we'll start the immunization. So in summary, we have had a case of a preterm baby who had very low birth weight, had RDS, sepsis, and meconium aspiration pneumonitis. In the course of management, they required CPAP, surfactant, antibiotics, and phototherapy. We had a very stable baby at day 18, discharged with a proper follow-up plan. That is the end of case 1.
Excellent. Yeah, thank you. Thank you for this so far. I would like us to take questions for this, then we will take the second case, just so that nothing is lost in this particular one. Okay, so you've got some questions for following this. One is Gloria is asking, hello, thank you. The baby was resuscitated with CPAP in theater. However, when we reached NICU, we were on room air. Could we not transport the baby on CPAP to NICU?
Thank you very much for that question. So yeah, in theater, we resuscitated and initiated CPAP, which was quite very good for the baby. Baby was transported still on CPAP. However, when we arrived and still on CPAP in NICU, we just had to reassess and establish the baseline for continuity of care because the team in the NICU was new to the care of the baby. So they just wanted to establish exactly the baseline of the child. So it was taken off, assessed, and then taken back to continue care, just to be sure where we stood with the baby.
Good, thank you very much. I hope that answers the question Dr. Gloria asked. Arineta is asking, was the TFI 8 mLs or 8 mLs per kg per day? I think you mentioned it, these figures earlier.
It was 80 mils per kilo per day. I just missed out the units, but I meant to say 80 mils per kilo per day. Sorry for that.
All right, and Eddie is asking which intubation medication was used during the intubation of the kiddo.
So we did not use any medication for the baby.
Okay, so
Yeah.
All right, that's good clarification as well. And then Gloria is asking, the baby was started on EBM on day 3. Was there a contraindication starting it earlier? Maybe on day 2?
Thank you so much, Gloria, for the question. No, so ideally, EBM is introduced on day 2. Day 1 is usually for D10, and then day 2 is usually for, you start to introduce the EBM. So this was a preterm, quite small, and we had a picture of meconium aspiration and also RDS. So much as they had been stable on day 1 with a CPAP, there's a very high risk that we could most likely topple into severe distress, that brings us to intubate the baby back and the subsequent management. So day 2, when we should have introduced the EPM, we wanted to first observe and be sure that the baby could improve steadily on the CPAP before we could go for the EBM. But ideally, the EBM should be introduced on day 2. But in this case, we wanted to be sure that the distress was improving.
And then Fiona is asking about the vitamin K that the baby was given 1.3 milligrams, yet the guidelines say vitamin K should be 0.5 milligrams for neonates less than 1.5 kgs. So Dr. Fiona is asking why this baby got 1.3 milligrams of vitamin K, yet the guidelines recommend 0.5 milligrams for neonates less than 1.5 kgs.
I think that might have been an oversight on our side.
It's okay. We'll probably have comments to it from the rest of the team later on. I guess the final question I will take for this segment is from Moses again. Is saying he missed something, like on day 0, the baby gave 13 or 26 milligrams. So the baby got 13 milligrams of caffeine, Dr. Renaitre. So I think that was what was mentioned in the talk. All right, Doctor, you can still bring more questions in onto the chat and we shall respond to them in the background. But in the meantime, I would like the speaker to proceed to the second case. Please.
Thank you so much for the questions. Let's continue with the second case. We should be very brief and then attend back to the question. So the second case, we had our 32-year-old female, gravida 3/2+0, who had attended all antenatal visits and had no prenatal complications. Needless to say, she had no complications throughout the pregnancy.
Go ahead, Doctor.
Okay. We had she was at gestation age of 39 weeks of amenorrhea. She was treated for an elective cesarean section due to 2 previous scars. It was done, the elective cesarean section was performed, and we had a birth weight of 3.5 kilograms. The baby was male. So at delivery, we had an APGAR score of 8 at 1 minute, 9 at 5 minutes. At this point, we had a tachypnea of 75 beats per minute. We had a Silver-Anderson score of 4/10, and there was no significant diagnosis noted. So the initial vitals, we had a heart rate of 144, respiratory rate of 75, and SpO2 was 87 on room air. We initiated a neopaf it's a CPAP, we initiated CPAP via neopaf in the delivery room. We had a peak inspiratory pressure set at 15 centimeters of water. We had a PEEP of 5 centimeters, and then FiO2 of 100% administered to the child. This was given for about 45 minutes to an hour in theater. The response, we had mild improvement. The rate was 73 beats per minute, but the SpO2 improved to 90 from 87. Notably, the rate remained elevated. So we decided to transfer the baby to the NICU. On arrival, we had a pink, active baby in mild to moderate respiratory distress, who had a respiratory rate of 74, heart rate of 146, SpO2 of 90 on room air, and would improve when administered oxygen via nosoprones. Temperature was 37.2. The respiratory system, we had increased work of breathing, noted by nasoflaring, retractions, and mild grunting. We had equal air entry bilaterally. CVS was unremarkable. Her abdomen was unremarkable as well. CNS, we had an active baby. We had normal tone and reflexes. We had a flat anterior fontanelle as well. The skin was pink. We had good perfusion with no bruises or edema. At this point, our differential diagnosis was transient tachypnea of the newborn based on the history of delivery. Baby was delivered by cesarean section. Yeah, and had no examination as well. The other differential was congenital heart disease that could give you similar symptoms. So the management plan at this point was to institute oxygen support via nasal prongs. It was started at 2 liters per minute, targeting an SpO2 of 90 to 94. IV fluids were to be given through IV, that is D10, still at 80 mL per kilo per day, because this was a term baby who had mild respiratory distress. Monitoring was to be done, work of breathing and vitals. So a CBC was done. We had a normal CBC, and then clinical progress. So we had, baby was reviewed later on day 1 and also on day 2. Later on day 1, we had a SASS score of 3. It had improved from 4 to 3. And on day 2, we have a SASS score of 0. Still on day 1 review, we had a tachypnea of 66, but it has an improvement from 73. Baby was still on oxygen via nasal prongs of 2 liters. And the feeding, at this point, since we had improved the distress was reduced. So we opted to start half EBM and half D10. So EBM was given at 40 mL per kilo per day, while the dextrose was maintained at 40 mL per kilo per day. On day 2, our SASS score was 0. The respiratory rate was 51, and the baby was saturating about 92, 94 on room air. Feeding at this point was at EBM, 100 mL per kilo per day, and the child was discharged on day 2 later that day. So at discharge, we had a stable respiratory rate ranging from 40 to 60, normal for age. We had no oxygen requirement, were tolerating full oral feeds, and we had no signs of infection or worsening symptoms. There were no antibiotics administered. Baby was discharged to the mother. So the summary, we had our TTN, transient tachypnea of the newborn, that resolved within 48 hours in a term baby, delivered by cesarean section, managed with a NeoPAP for about an hour, that is a CPAP, transitioned to nasal prongs in the NICU for about 36 hours. Supportive care was given via oxygen, fluids, and feeding. And the outcome, we had a full recovery, discharge on day 2. Thank you very much. I invite questions.
All right, excellent. Again, thank you for quick fire, cases. And yeah, we have one more question on the chat. This is from Dr. Rona, asking, how D10 and aspiration risk are connected, and why you started TFI of 80 on day 1. I'm not sure if it's for this particular case or the previous one. Dr. Rona, could you unmute and ask your question directly?
Yes. Thank you so much, Doctor. Good evening, everyone. They told us that they started TFI of 80 because they were scared of aspiration risk, and I'm wondering how IVD10 is connected to aspiration risk for this particular patient of TTN. Then another question is, I'm wondering why we didn't start at a TFI of 60 instead of 80.
All right, Doctor Winnie, do you have an answer to this, or should we defer it to the pediatricians?
Maybe I'll attempt to answer one. The D10 and aspiration risk. So that was in reference to where we couldn't start the EBM on day 1 because of baby was in distress, so we could just give dextrose instead of EBM on day 1 TTN. I hope that answers it. And then why we didn't start at 60 versus 80. So there are different schools of thought. When we have a term baby who has no distress, has no issues, we occasionally start at 80 mils. However, when you have distress, and depending on how severe it is, we occasionally start at 60 as well. But I would definitely get some more clarification from the pediatricians on that.
All right, so let's see the other questions. Eventually, I'll ask the pediatrician just respond to this before they start their talks in a bit. So, all right, so in the next 2 minutes, let's see. Next question is, why was the SASS score used and not the Down score in a term baby? This is the question from Catherine.
That's my question, Dr. Erasmus.
The question is, why was a SAS score, a Silverman Anderson score, used rather than a down score in the term baby, the second case?
I'll pass that question.
Okay, all right. Thank you very much, Doctor. Do we have any burning question before I invite the next speaker? She could just unmute and ask. Anyone? 10 seconds. All right, so thank you so much, Dr. Winnie. You could may retire your screen. All right, so I would like to invite our next speaker. Our next speaker is a friend, a brother to me, so kind of proud at this moment. He is a gentleman I work with. He's a pediatrician who loves children, loves babies especially, and you find him awake in the middle of the night. He's Dr. Daniel Lukuya. He is a pediatrician at TMR International Hospital, and he's going
Erasmus, I think we've lost you.
Hello, everybody.
I think Daniel can go ahead. I think Erasmus' microphone.
Take us through and take on my screen share.
Dr. Erasmus, we lost you for a bit.
Yeah, so sorry. I was inviting Dr. Lukuya to share his screen, and I also needed him to just respond to some of the questions that were asked, specifically the choice of fluid to start with in terms of the dose. There's a question on why we started with the 80 mils rather than 60 mils per kg body weight per day for the neonate, and then also the question of using the SAS score over the down score in the term baby. Dr. Lukuya, over to you. I'm going to unshare my screen and share yours.
Thank you, Dr. Erasmus. Good evening, everyone. I'm happy to be here today. For the choice of fluids, for the newborn, usually in the first 48 hours, we like using dextrose 10%. For children above 1.5 kilos, preferably, unless there's a contraindication, we normally start at about 60 mils per kg per day. There are scenarios where we do lower it to about 40 when we're worried about things to do maybe with cerebral edema or fluid overload and hydrops fetalis, or in others where we may need to increase the fluid if the baby was not maybe born in the hospital and had prolonged exposure, and we notice that the baby is dehydrated. The choices between the Silverman-Anderson score and the Down score. Downs is more comprehensive, but we have had it has not been widely taught to be used among a number of the clinical people. So in order for uniformity, the Silverman-Anderson score has been used more readily. However, the down score is more comprehensive because of the areas that it touches, and it is generally it's more sensitive with respiratory distress. However, for preterms, the Silverman-Anderson score is sensitive for the hyaline membrane disease, which is the RDS that they have. I hope that answers your question, Dr. Rona. Without further ado, let me jump straight. I've been asked, and it's with great pleasure that I will take you through 3 topics. I will try to be brief because they're quite wide. We may skim through a few aspects of the case, but please do share your questions, and Dr. Erasmus will help me capture some of them as we go through. To start us off, we'll be dealing with transient tachypnea of the newborn, meconium aspiration, and then persistent pulmonary hypertension of the newborn. So transient tachypnea of the newborn, which is also referred to as TTN, it's a parenchymal lung disease characterized by pulmonary edema resulting from delayed resorption and clearance of fetal alveolar fluid. So we tend to see this more in the late preterms and the term neonates, and it's generally benign and self-limiting. So the late gestation changes that usually occur in the neonates, we have the increase in the catecholamines and other hormones that mature lung epithelium, and there's a switch from the secretion of the chloride, which happens within the alveoli, to the air sacs, to absorption of sodium and the neonatal fluid that, and the amniotic fluid that's within the lungs. Now, this fluid, if it's not absorbed, it will interfere with oxygen tension within the lung. So the birth processes as occurring, it enhances the sodium channel expressions, leading to enhanced sodium and water absorption. Now, immature lungs have reduced expression of this of the sodium channels. So this increases the retention of the fluid and reduces its absorption. So there is a passive resorption that tends to occur during late trimester, third trimester gestation and the delivery processes. So during birth, we have differences in the oncotic pressure in the air spaces within the interstitium, and these blood vessels, and the water is squeezed first mechanically as the child is passing through the birth canal, and this primarily triggers the aquaporin 5 water channels for the absorption of the sodium and the water. So if there's a delay in the resorption of this water, it will remain in the alveoli and the interstitium, and this pulling will cause perivascular tissue and the interlocular fissures to have what would seem like pulmonary edema. This will cause decreased compliance of the lung, and it will increase the work of breathing. So when we look at these children, the airway, we notice that there is peribronchial, bronchial, lymphatic absorption is reduced, the bronchioles tend to collapse, and there's air trapping. Gaseous exchange is usually affected, and this leads to hypoxemia and alveolar edema, which in turn will affect ventilation and sometimes cause hypercapnia. The proposed mechanisms, there are a few theories that have come up. So this, with the retention of the fluid, this will decrease the function of surfactant and reduce the synthesis of nitric oxide due to the upregulation of the asymmetric dimethyl arginine, the ADMA levels, which further reduce levels of nitric oxide within the lungs. The epidemiology and risk factors of TTN, cesarean section is the largest cause of, or largest risk factor for TTN compared to vaginal delivery. And we notice that there's in vaginal delivery, it's about a 1.1% of all term or late preterm deliveries, while it's a 3.5% in the term infant. The gestational age is higher in late preterms than for the term neonates, especially gestation age between 37 to 40 weeks, and those delivered by elective cesarean section. Those that undergo labor and end up in cesarean section tend to have a less incident of TTN due to the stress that they undergo during the labor process. The maternal conditions that have been highlighted that seem to cause an increase in TTN incidence in the neonates, we have children of diabetic mothers, mothers that are obese, and those that may have chronic disease like maternal asthma have been noted as factors that increase the risk of TTN. So on its onset, TTN usually occurs between birth and the first 2 hours within delivery. And we notice this by a respiratory rate greater than 60 breaths per minute. In symptomology, infants with more serious disease will have cyanosis, increased work of breathing, they'll have nasal flaring, mild intercostal and subcostal recessions, and expiratory grunting. The anterior posterior chest diameter sometimes is increased. On examination, the breath sounds are affected. The affected infants are typically clear. They normally don't have the rhonchi and the rales or capitations. And these infants tend to have usually between mild and moderate TTN. And usually within 12 to 24 hours, they have cleared, it has cleared. However, any symptoms that do last longer than 72 hours are considered severe cases, and we have to investigate for other possible causes of the TTN. On the chest X-ray, the main characteristic findings that we normally have is that they have a flattened diaphragm. This is increased lung volume because of the air trapping. They may have mild cardiomegaly and prominent vascular markings, which pathognomonically are called the sunburst pattern that are seen around the hilar. Fluid is often seen in the interlobular fissures, and pulmonary effusion may be present. Lung ultrasound seems to be very effective in helping us identify pulmonary edema in these children with the compact B lines. These are the hypoechoic lines that are rising from the pleural surfaces. Differential imaging, unlike in pneumonia or RDS, TTN does not show areas of alveolar densities, consolidation, ground glass appearance, or air bronchograms. We have an X-ray that would show a few of the features. So in the first one, in A, you can notice that the diaphragm looks mostly on the right, but also on the left, there's a bit of flattening of the diaphragm. There is a mild cardiomegaly on that one. But in B, you see that sunburst appearance where the cardiac shadow seems to be, it's not clearly defined. So this is mostly because of the pleural and intrapulmonary fluid that is obscuring the heart shadow. So the diagnosis and differential diagnosis. So TTN is a clinical diagnosis based on the respiratory distress presenting shortly after delivery and the characteristic findings on chest X-ray. Diagnosis can be confirmed with resolution within 12 to 24 hours. Typically, infants with TTN do not have persistent respiratory distress beyond 24 to 48 hours. And this may require higher oxygen concentrations greater than 60%. The other differentials could be neonatal pneumonia, especially if we do have things to do with like chorioamnitis or PPROM or PROM that occurs, prolonged rupture of membranes, increased risk of exposure, and anything that may trigger infection in these children. Neonatal sepsis can also present with respiratory distress, so those ones do have a positive blood culture. And then congenital cardiac disease usually tend to have tend to show up also a bit early for some of the cases. And then in respiratory distress syndrome, we have the ground glass appearance with air bronchograms. The management with essentially supportive care. So thermoregulation, we make sure that the babies are kept nice and warm in the radiant warmers, or the incubator. In low resource settings, we encourage skin to skin with the mother if she's able to do so. This normally helps to improve peripheral circulation and also reduce the anxiety of the neonate. In the nutrition, with respiratory rates greater than 60 and 80 breaths, we tend to try to avoid putting the baby on the breast because of risk of aspiration. So if we are to feed the children orally, we do pass an orogastric tube or an nasogastric tube, depending on the delivery of oxygen, whether it's nasal prongs, free flow oxygen, or CPAP. Most times, supplemental oxygen by free flow nasal cannulas are okay. However, for those that seem to have increased work of breathing, nasal CPAP tend to be a bit more effective. So when the work of breathing increases or they're having features of hypoxemia, then CPAP has to be used. However, from my experience, I noticed that early initiation of CPAP actually reduces the stay of the children within the NICU and nursery. Alternative supports, we can have things like the nasal intermittent positive pressure ventilation, which we have not used readily and frequently. And then escalation of care. So it's unusual for infants with TTN to require higher levels of respiratory support. The newborn requires it, then there is probably something else that is causing this respiratory distress, such as mentioned above, sepsis, neonatal pneumonia, or respiratory distress. Fluid management. So the schools of thought believed at the time that because it's fluid accumulation within the lung, it should be fluid restriction. However, in our setting, we try not to restrict the fluid. And since these children are usually late preterms and term neonates, we normally do at the 60 mils per kg per day fluid management, unless other indications show up. In my reading, I found that the clinical trials on beta agonist and corticosteroid used to try to improve the outcome. However, it has not shown such large difference in timing and the rest. Importantly, what has been noted that giving the mother corticosteroids prior to delivery, 24 hours prior to delivery, has been shown to improve in some studies. However, it's also not yet conclusive. And the prognosis of TTN is very good, but if the tachypnea and the distress persists, then we have to look for an alternative cause. All right, Dr. Erasmus, should we take questions now or we complete all three? Then
let's complete all the three, then we should come back to questions.
Okay. So next up, we will talk about meconium aspiration syndrome. So meconium aspiration syndrome, also known as MAS, is defined as respiratory distress in newborn infants, neonates that are born through meconium-stained amniotic fluid, and whose response cannot be otherwise explained. MAS can present with varying degrees of severity, from mild respiratory distress to life-threatening respiratory failure. So with changes in the obstetric care, and incidence of MAS has declined significantly in the West. However, in our setting, in the private healthcare, it's significantly reduced as well. However, in government setting, meconium aspiration, due to late referrals and the use of traditional birth attendants who delay referral to health centers, still pose an increased risk of meconium aspiration in the neonates. So in the United States, the rate is about 0.1 to 0.4% per every live birth. In Uganda, we are at about 2% of every live birth in a study that was done in 2020. The meconium aspiration rates by gestational age tends to increase with post date. However, preterms, like in the case that we saw, was also present. So anything that will cause the children to pass stress, cause distress to the children in the womb and cause meconium aspiration. So the risk factors, as we can see, are intrauterine growth restriction, vaginal breech delivery, cesarean delivery, emergency cesarean deliveries, non-reassuring fetal hearts, low APGAR scores, and maternal fevers or infections. So meconium is a sterile, thick, black-green, borderless material, first demonstrable in the fetal intestines during the 3rd month of gestation. It results from accumulation of debris, including squamated cells, intestine, skin, and the gastrointestinal mucin, lanugo hair, fatty material from the vernix gaseosa, amniotic fluid, and the intestinal secretions. So normal fetal defecation, the defecation with meconium normally begins in early life in the 1st trimester and slows down after 16 weeks. This becomes frequent by about 20 weeks. Concurrent with innervation of the anal sphincter, the approximately 20 to 34 weeks gestation. And then the fetal passage of meconium remains infrequent. So the stress-induced passage of meconium occurs when there's fetal stress resulting in meconium passage. This can be due to increased peristalsis and relaxation of the anal sphincter from increased vaginal outflow. And this can be associated with umbilical cord compression, increased sympathetic inflow during hypoxia. So the intrauterine aspiration of pneumonia, this occurs when the fluid is aspirated during fetal gasping and initial breaths after delivery. Prolonged hypoxia stimulates fetal breathing and the gasp that can lead to inhalation of amniotic fluid. So if the meconium has been passed within the amniotic fluid, this can be found in children that are stillborn, those that are without history of aspiration at delivery. So in case there's anything that stresses the baby that's not being monitored, so when the babies are delivered, they may be able to find meconium in the lungs. Postnatal aspiration, this occurs usually due to the hypopharynx or trachea after delivery and is aspirated during the initial breaths. As we saw in the case earlier, the preterm actually had the meconium state secretion within the trachea when it was intubated and suctioned. We were able to clear it before a lot of it would actually settle within the alveoli. So meconium, when aspirated into the fetal neonatal lung, causes pulmonary injury and the airway obstruction and inflammation and hypoxemia. So there is pulmonary injury, and this can severe pulmonary manifestations of mass are a consequence of underlying intrauterine pathological processes, including airway obstruction, inflammation, infection that lead to hypoxemia and potentially persistent pulmonary hypertension. So the mechanism of pulmonary disease, we have the airway obstruction. So the meconium plug can completely or partially obstruct the airway, and complete obstruction can cause distal atelectasis. And then when it partially closes the airway, it creates the ball and valve effect. So this leads to overdistension of the lung and alveoli rupture with resulting pneumothorax and air leak with its complications such as pneumothorax or subcutaneous emphysema. There was actually an interesting case that we had, I had several years ago, a child that had this and presented at 3 months of life with a collapsed right lung. But the pneumothorax was slow leaking. And when the child got bronchiolitis for the first time, it worsened the breathing one. And when we did a chest X-ray, we were quite surprised. Only when we took history, clearly we found that the child had been born through meconium. The other way can be through inflammation of the lungs. And this is the direct injury and inflammation results from exudative and inflammatory pneumonitis and epithelial disruption, which can later cause alveolar collapse and cellular necrosis. The infection So meconium-stained amniotic fluid is a marker for bacterial infection in a amniotic cavity. Although meconium is sterile, the mucopolysaccharide component provides an excellent growth medium for microorganisms, especially E. coli, and the meconium can also inhibit phagocytosis by polymorphonuclear cells and their oxidative bursts. So for any child that is born with meconium aspiration, there is a child that has meconium aspiration, there is a need to be quite sensitive for possible sepsis if there is prolonged rupture of membranes. The hypoxemia and the clinical manifestations. So the cause of the hypoxemia results from decreased alveoli ventilation related to the injury of ventilation. And this is often due to associated persistent pulmonary hypertension with the right to left shunting that causes increased pulmonary vascular resistance. So the general clinical symptoms that we normally see with meconium staining of the infant, so we have vernix, the umbilical cord, the nails, maybe meconium stain, depending on how long they have been exposed to it. Perinatal asphyxia occurs between 20 to 33% of the children born through meconium-stained amniotic fluid. The growth patterns, so affected infants are frequently small for gestational age. They're born post-term, and the characteristic findings that we normally see are peeling skin, long nails, and decreased vernix. So that is for the post-date children that seem to be at risk of meconium aspiration. They also do have, they present with respiratory distress, tachypnea, cyanosis that occur immediately after birth, and they have the use of accessory respiratory muscles. On the physical examination, the affected infants tend to have a barrel chest. So this is because of the air trapping that occurs, and there's an increased anterior-posterior diameter caused by an overinflation. On auscultation, we may hear some crepitation or rales or bronchi. And this distinguishes meconium aspiration from neonatal respiratory distress. Under complications, this in patients with severe mass tend to have a pneumothorax, pneumomediastinum, and they have forms of severe disease and require mechanical ventilation when they have respiratory failure. So the severe respiratory disease is often associated with persistent pulmonary hypertension of them. When we evaluate them, we have to do a chest X-ray, and these tend to show us streaky linear densities, and this, as the disease progresses, there is typically hyperinflation and flattening of the diaphragms. We have to do echoes in these children because one of the most common causes of persistent PPHN is meconium aspiration. However, we also have to rule out possible cardiac cause for the respiratory distress. We do have to do cultures and do antibiotics and take off our labs, our infection screening. The oxygenation assessment for adequate oxygenation. For these infants, supplemental oxygen and arterial blood gas requirements may be done, and that will demonstrate hypoxemia or hypercapnia. So the diagnosis is clinical. So all children born through meconium stain are at risk of meconium aspiration syndrome. Any child that has RDS and meconium stain is typically a mass until proven otherwise. So when you do the chest X-ray and you're able to see what is seen, you may also use it to strengthen your diagnosis. Tracheomeconium, so if, like in the case, you notice that despite being on appropriate CPAP or care at the point and we are not improving, there is a possibility that we are having a meconium plug blocking the airway, and intubation and clearing the airway could be life-saving and could also reduce length of stay in the hospital. So these are some of the images. This is the same child with meconium aspiration through the course. So Immediately after birth, we have the first image, and the second image came on day 5, and then the third image, which is C, came on day 12. So they had worsening images and remained on CPAP for quite some time. So other differential diagnoses that we do have for meconium aspiration, we have TTN, we have pneumonia, we have congenital heart defects, we have RDS, PPHN, congenital diaphragmatic hernia, and pulmonary air leaks such as pneumothorax. So in the delivery room, we have to clear the airway as quickly as possible and start ventilation. However, the American Association of Pediatrics and ACOG believe that suctioning does not change the outcome. However, that is still up for discussion. The standard resuscitation should be carried out, close monitoring case of the respiratory rate, heart rate, and signs of obstruction. Selective endotracheal suctioning can be done in some of the cases to help improve oxygenation. So under the initial assessment, so the immediate evaluation should be done as quickly as possible. We have to admit in NICU any child that has a score less than 9 at 5 minutes. And then symptomatic neonates should be monitored for at least 4 to 6 hours. Normal nursery criteria can be taken care, put on oxygen, the IV fluid management, and then keeping the baby warm. The only caveat we have to this is if the child has started showing features of HIE, hypoxic ischemic encephalopathy, then there we have to do cooling. The respiratory support strategies that we do, we have oxygen therapy, we have mild, in mild to moderate disease, you can use free flow oxygen, or you can step up to CPAP. And for those in severe respiratory distress, so this one's a SARS score of greater than 8, will probably need to ventilate all those with respiratory failure. So hemodynamically, we do have to give the monitor their fluid outcome, input and output. We typically prefer to use dextrose 10%, but those that do require volume expansion, then we can use saline for volume expansion. For those with severe, moderate to severe mass, we have to start them on broad spectrum antibiotics, ampicillin, gentamicin, after taking off cultures. The advanced interventions, for those with moderate to severe, we normally give them surfactant, we intubate and give surfactant. Inhaled nitric oxide has been shown to improve and prevent PPHN. And if one day we may be able to do ECMO in our settings as well. So for those that do have quite severe mass, we do opt for sedation and analgesia to help prevent PPHN. So mortality is, we have varying between the developed countries and the developing countries. In Uganda, we do have a high mortality rate for severe meconium aspiration. However, it tends to improve with immediate action. Neurodevelopmental impairment can occur. These are children that will end up with hypoxic ischemic encephalopathy, and those with severe complications tend to have a longer hospital stay, and outcome may be a bit worse. So fetal monitoring, amnioinfusion, when possible, and preventing postpartum deliveries are some of the prevention strategies that we can use for prevention of meconium aspiration. So the management principles: respiratory support, hemodynamic stability, infection control, and minimal handling tends to help us out. Quickly, persistent pulmonary hypertension is one of the a wider topic. I will try to be as brief as possible, but try to capture some of the pertinent points that we can use. So this occurs when the pulmonary vascular resistance remains abnormally elevated after birth, and this results to a right to left shunting of blood through the fetal circulatory pathways, leading to severe hypoxemia, and that may not respond to the conventional respiratory support. PPHN affects approximately 2 per 1,000 live births, and most patients present within the first 24 hours with respiratory distress cyanosis, prompting diagnosis and management. So fetal versus postnatal circulation. In the fetus, pulmonary and systemic circuits operate in parallel. Both ventricles eject blood into the aorta, the subsequent perfusion from placenta. The right ventricle is dominant and the blood is shunted to right to left, though the foramen ovale and the ductus arteriosus are patent. The transitional circulation at birth, the major circulatory adjustments that occur as gaseous exchange shifts from placenta to the lungs, and progressive fall in the pulmonary vascular resistance accompanies an immediate rise in systemic vascular resistance, creating transitional pattern. So a mature postnatal circulation, the circulation operates in series, and all venous returns through the right heart into the lungs for gaseous exchange, and oxygenated blood returns to the heart and is pumped for systemic circulation. So this is an image. So from the placenta, as you can see, the umbilical vein being red in this case, because it has the oxygenated blood from the placenta, goes through and joins the inferior vena cava and goes into the right atrium. Then down, it cuts across into the left atrium and then into the right ventricle and then into systemic circulation. But we do have moderate pressure flowing into the right atrium, the right ventricle that will go into the lungs, but it's shunted still more from the pulmonary trunk into the aorta to provide systemic circulation. So the pathophysiology of PPHN, we have under development. So reduced cross-sectional area of the pulmonary vasculature creates a relative fixed elevation in the pulmonary vascular resistance. And this is associated with the highest mortality as adaptive. We have abnormal thickening of the muscle layer in the pulmonary arterioles and an extension into the small vessels that normally have thin walls. This excessive extracellular matrix surrounds the vessel. While the maladaptation, normal vasculature development, but adverse perinatal conditions can cause vasoconstriction and interfere with normal postnatal fall in pulmonary vascular pressure. So this is where we see things like meconium aspiration, genital diaphragmatic hernia, and things of the sort. The abnormalities can involve disruption of vascular endothelial growth factor signaling, and the genetic factors may also influence availability of precursors for nitric oxide synthesis, affecting cardiopulmonary adaptation at birth. So the risk factors for PPHN, maternal factors, we have gestational diabetes or pre-existing diabetes, obesity, advanced maternal age, use of SSRI exposure during pregnancy, and then those that are of the Black race. Fetal neonatal factors, we have meconium aspiration, large or small gestational age, post-term delivery, and prolonged premature rupture of membranes. Conditions associated with underdevelopment, we have congenital diaphragmatic hernia, pulmonary hypoplasia, rhinogenesis, and oligohydramnios. The clinical manifestations that we usually have is respiratory distress within the first 24 hours. We have cyanosis and then cardiac findings. So this will have a prominent precordial impulse and narrowly split. Accentuated second heart sounds and a harsh systolic murmur consistent with a tricuspid insufficiency may be heard at the lower left sternal border. Associated conditions, we have most infants with PPHN associated with respiratory or systemic conditions. Mass accounts for about 25 to 40%. Sepsis is about 20 to 30%, pneumonia 15 to 20, and 15 to 20 as well are idiopathic. Respiratory distress syndrome accounts for 10, while congenital diaphragmatic hernia represents 5 to 10%. In pulse oximetry, when you have a difference of about 10%, this will suggest a right to left shunting in the pre and the postductal saturations, right thumb greater than the great toe. Arterial blood gases can be done when we have the partial pressure of oxygen less than 100 millimeters of mercury, despite 100% oxygenation. And with ppn, at least one measurement of the partial pressure of oxygen greater than 100 in early illness may distinguish them from a cyanotic heart disease. The chest X-ray may be normal or could show associated features. The heart size typically is normal or slightly enlarged. The pulmonary vasculature may appear normal or reduced. Sepsis evaluation has to be done to make sure that the cause is not a neonatal pneumonia or neonatal sepsis. Echo is diagnostic instrument of choice. They normally do have a normal heart structure, ruling out congenital heart defects that could have similar presentation. Elevated right ventricular pressure will show us, allows estimation of the right ventricular pressure and tricuspid regurgitation jet velocities. Right to left shunting may also be seen. So in severe pulmonary hypertension, echo will demonstrate right to left shunting through the patent ductus arteriosus or foramen vale. The severity classification, severe PPHN, we have right ventricular pressure exceeding systemic blood pressure. Moderate to severe, we have about 75% of the systemic blood pressure, while mild to moderate, we have the pressure being between 50 to 75% of systemic blood pressure. Echo will provide us crucial information about the severity of pulmonary hypertension, and comparing the estimated right ventricular pressure to the systemic pressure is important. So one of the things that we also have to do is, if possible, the children with respiratory distress do take their blood pressure. This will help the cardiologists when they're doing the echo. Excuse me. The differential diagnoses that we have cyanotic heart disease, primary parenchymal lung diseases like pneumonia, meconium aspiration, TTN, RDS. Sepsis can also cause alveoli capillary dysplasia, also be one of the differentials. The general principles of care. The setting of care is very important. These children have to be managed in a NICU, and staff that have to be experienced in PPHN care. In the severe cases, should be managed in centers that have with the ability to escalate the care. I know inhaled nitric oxide and ECMO are not readily available for us. However, hopefully soon we shall have those modalities also available. General supportive care in the newborns, we have depressed at birth and resuscitated promptly, monitor closely, and we have to take care, especially with the pulmonary vascular resistance, supplemental oxygen, mechanical ventilation, and hemodynamic support. We also have to treat the underlying cause if it's meconium aspiration, sepsis, pneumonia, RDS, or congenital diaphragmatic hernia. The oxygenation index. So if there's hypoxemia, severe hypoxemia, this is where we'll probably have to do the inhaled nitric oxide or ECMO. So we have a MAP and an FiO2 divided by the partial pressure of oxygen. You multiply that by 100. The hypoxic categories. So in mild hypoxemia, when it's less than 5, moderate is greater than less than 15, moderate is greater than 15, severe. Severe is those greater than 40%. So the severity of pulmonary hypertension is categorized based on the estimated right ventricular pressure relative to systemic blood pressure. So mild to moderate is half to 3/4 of the systemic, while moderate to severe is greater than 3/4. So initial ventilation is as we manage these children, The initial ventilation is very important. So we have to start, if you notice a child with respiratory distress that is not improving, do start ventilation, escalate from free flow to CPAP. We have seen great strides made with those that CPAP was started early. Don't end up on mechanical ventilation. However, for the severe cases, ventilate early to prevent complications. These children have to be sedated. We use fentanyl or morphine. In some cases, we do use a bit of midazolam, and we do make sure that the children are in a cool, a nice environment, not extremes of temperature, not cold, not hot. Manage the lighting, reduce the noise, because when they're agitated, this increases the pulmonary vascular resistance, which worsens the pressures. Hemodynamic support is also very important. And then the escalation of care for children that are not responding well. Do not hesitate to ventilate and sedate. So we have to monitor the parameters, the pre and post-duct oxygen saturation, serial clinical assessment, perfusion, so the cup refill, blood pressure. Serial ABGs can be done. Ventilation data and echo, just x-rays are very important. So our pre-ductal targets are 90 to 95, with partial pressure of oxygen between 40 to 45. Hemodynamic targets, we normally want BP of between 45 to 55, systolic 50 to 70. I will not dwell on this. However, it has been shown to be the most effective therapy for PPHN, the inhaled nitric oxide. The way it works is nitric oxide is a potent pulmonary vasodilator that decreases pulmonary artery pressures, and this improves oxygenation by dilatation of vessels. And this tends to reduce the changes that occur with PPHN. The dosing is usually 20 puffs per minute. And then in responders, you improve the partial pressure of oxygen and SpO2 by about 20% within 20 minutes. The weaning usually begins with FiO2 of 0.6%, decreasing it down. The efficacy in the randomized trials and meta-analysis, this has improved oxygenation and reduces need for ECMO in term and late preterms. We do also give surfactant in our setting to help improve lung compliance. And then sometimes you do have to give blood transfusion to help improve the hematocrit, the oxygen carrying capacity. Sildenafil at the moment is our drug of choice. We normally give in 0.5 to 2 milligrams per kilogram, 6 hourly. And then the IV dosing is about 0.4 milligrams per kilo. In many settings, we do have to give it with hydrocortisone because in some neonates, we have noticed that it can cause hypotension. ECMO, the indication is usually if they have failed on nitric oxide, then they have to go ECMO. Hopefully one day we shall be able to carry this out as well. Mortality, the developed world has been between 7 to 10%. In our setting, I failed to find appropriate data for it. The readmission rates there is about 28 to 0.6 with those that survive PPHN, and 9.8% of the infants without PPHN. The relative risks, the survivors were more likely to have died from post-discharge and readmitted within the past year. The survivors of severe PPHN and ECMO treatment at increased risk of developmental delay, motor disability, hearing defects, chronic health problems, and the others. Data do underscore the need for close follow-up of all the survivors. So, from the 3 topics that I have mentioned, delivery room CPAP has been a game changer for us. And we do also encourage close vigilance, and please investigate these children as quickly and as appropriately as possible so that we may catch some of these early. Thank you so much for your time. I've taken a lot of it.
Not at all, Doc. This is great. Thank you. Thank you. I've listened to you all evening. Thank you so much for covering these wide topics in this quite informative way in the limited period that we've taken. I would like to open up the chat for questions, and we've got quite a number of questions that have come in since. So we will go to the first question from Fiona regarding TTN. What puts infants, or better neonates of diabetic mothers at risk of TTN?
Thank you, Fiona, for the question. The exact mechanism was not known. There were a few theories that had been brought forward because of the infantile insulin, the fetal insulin concentration. However, conclusively, they had not put one forward. But there are a few hypotheses that have been put forward.
Okay, I guess one of those was the fact that perhaps more children of diabetic mothers end up with C-section, and therefore having C-section will directly increase the risk of TTN.
Yeah.
Is there any other that you might have found that maybe might lend a bit more mechanism?
Not at this time. Maybe Dr. Helen can help me out.
Okay. All right. Yeah, maybe also we can expand to look at the treatment as well. If the treatment of TTN of diabetes in the mother might have an impact on the fetal well-being. But I guess the fact also that diabetes, diabetic mothers generally have developmental issues to do with the babies, high risk of developmental issues with the baby, which might also include the channels, the enough channels and the like. I don't know. We shall definitely hear from Dr. Helen if there's any other mechanisms. But yeah, not a clear mechanism. Thank you. So talk about CPAP versus high flow nasal oxygen in TTN and MAS. Any experience or data to support either modality? If you had both, what would you choose based on the setting and factoring in the institutional capacity of oxygen?
For the neonates, from what we have experienced with TTN, the use of CPAP because of the continued positive airway pressure, it helps us to expand the chest a bit faster, and helps us also to get the fluid out a bit faster. So the high flow nasal cannula oxygenation. From experience, because I have had the use of just plain nasal prongs, and at high flow oxygen versus CPAP, we notice that the CPAP is superior because of the pressure generation within the chest, so it helps us breathe a bit faster. However, I have not used the HFNO in children personally, so I don't think I am at the best person to speak on it. But I do think, from personal experience, CPAP has been nasal CPAP has been quite effective, reducing length of stay in the NICU.
Excellent, Doctor. Thank you. And then I guess the final question on the chat is, can you comment on pulmonary hypertension in newborn management in Uganda with regards to pulmonary vasodilators available and the effectiveness, given that INO is definitely out of question?
So I have had the privilege of treating quite a number of PPHN that were confirmed on echo. The management stems, one, there is usually late diagnosis. A lot of them are just managed as respiratory distress, and PPHN has not been brought into the conversation for a number of facilities. until much later. So it's early diagnosis is one of the most important things that helps us with the management. So any child within 24 hours, you notice delayed improvement on the conventional oxygenation modalities that are used, PPHN should be investigated. The most common that I've seen outside of congenital diaphragmatic hernia and meconium aspiration are the late preterms, usually between 35 and 37 weeks, tends to be quite prevalent among them. And then this is also, that's where I've noticed CPAP tends to be quite helpful. It helps us with increased pulmonary expansion, which in turn helps to provide appropriate oxygenation, which is a good pulmonary vasodilator. So it helps us to manage appropriately. However, when quickly diagnosed, for children, if you're able to do ABGs, do it quickly, get the diagnosis in, and those with severe PPHN, get them to ventilate, sedate, and calm them down. Usually they do have good outcomes.
Okay, and I think in your talk also you did mention that unfortunately the INO would be the main drug of intervention of choice here, but since we don't have it, we are left trialing sildenafil, which has got mixed kind of results out there, with some being positive and in support of use of sildenafil, where there's no INO, but definitely no role seemingly in areas where there's INO, meaning it's definitely much better than placebo, but not any good if you have INO already. All right, thank you so much, Dr. Lukuya, and I would like to invite Dr. Cornelius to project for us the poll questions for now, before we go to the next speaker. Thank you. Dr. Cornelius?
The tool has been launched. 6 questions. Will probably take about 3 minutes. Everything Dr. Lukuya has mentioned is in the poll question, so it'll be pretty easy. So feel free to respond. In case you don't see the poll questions, you can, and using your phone, there are 3 there's a 3-dot menu on probably the lower right part of your phone that you can tap and launch the poll on your side. Okay, we have 2 minutes to go. Okay, as I've said, coming in, we'll probably close the poll once we hit 25% so that we can save on time. Or if the 3 minutes are all, if you still need to go up to 3 minutes to get the 25%. Okay, 30 seconds to go. Okay, about 5 seconds to go, and we've just crossed the 25% mark. So I will close the poll in case you still want to submit in the next 1-2 seconds. All right, so that's the end of the poll. I will share the results, and Dr. Kwe, I'll ask you to respond to each of the questions based on what the audience has also submitted. I hope you can see the poll, the results now. So the first question is, which of the following is the most significant risk factor for TTN? We have 68% of the audience say it's cesarean section without labor, compared to the other options. Dr. Lukwia, is the audience on point?
Yes, they are.
All right. Which of the following findings is most commonly associated with TTN on chest X-ray? Here we have quite a good distribution. The majority options were perihilar streaking and fluid in the fissures, and then which had 45%, and the other option is hyperlucency with flattened diaphragm. That's 36% of the audience. Your take, Dr. Lukwia.
I believe I agree with the crowd. It is the perihilar streaking and fluid in the fissures, but then the hyperlucent, the flattened diaphragm is one of the one that still pulls people away from.
Yeah. Okay, and then a 41-week newborn presents with severe respiratory distress, grunting, cyanosis. The chest X-ray shows fatty infiltrates, hyperinflation. Which of the following is the most likely diagnosis? Here the audience was clear. We have more than half, 55%, peaking meconium aspiration syndrome. Your take?
Yeah, on point.
All right. Question 4, which of the following findings suggests persistent pulmonary hypertension of the newborn in a newborn with mass? So we have 68% of the audience, a majority, mentioned preductal SpO2 in the right hand being more than a postductal SpO2 on the foot.
Yeah.
Okay, and then question 5, a newborn with meconium stained amniotic fluid is born with poor tone, heart rate is 90 beats per minute, weak respiratory effort. What is the most appropriate first step in management according to the current guidelines? 59% of the audience selected immediate suctioning of the airway before stimulation, and the next high number is positive pressure ventilation with 100% oxygen. I think this was the part where I think you can weigh in again.
Yeah, so currently we believe clearing the airway prior to stimulation and ventilation is still the most effective. Though, like I mentioned, the Association of American Association of Pediatricians is trying to see if just going straight for ventilation is still the most appropriate. However, I believe let's clear the airway, prevent mass as much as possible.
Yeah. So I think the trick in the question was current guidelines. Yes, you mentioned the guidelines seem to suggest. So if it's an academic exam, which one would you select for the audience to go with?
Clear the airway.
Clear the airway. All right. Okay. Then what is the best ventilatory strategy for a neonate with severe mass requiring mechanical ventilation? We have 55% of the audience selecting low tidal volume with permissive hypercapnia.
So on this one, I will actually bounce off to Dr. Helen for a bit of help. I've used both. I've had mixed results as well. I'd ask one of my seniors to step in.
All right, I think Dr. Helen will probably talk about that in her talk. Dr. Rasmus, over to you. I think the poll questions have been well responded to.
Thank you, Dr. Cornelius, for that. Yeah, so I think, Dr. Lukia, just before you step aside, a question came in late from Howard. She wanted to ask about the role of steroids in PPHN.
Yes,
you had mentioned that sometimes you add hydrocortisone to prevent hypotension that follows the use of sildenafil.
Yes, so we have noticed in a number of cases where we use sildenafil alone, we tend to get systemic hypotension. So this normally affects peripheral perfusion and increases length of stay. However, with the introduction of hydrocortisone, I have noticed that there is improvement in the peripheral perfusion and also reducing length of stay.
Right, thank you very much. Yeah, so certainly, if you're giving sildenafil, it's going to cause a systemic and venous, that is arterial and venous dilatation, and the drop in systemic pressures may increase the right to left shunting, worsening hypoxemia. So something that boosts the systemic circulation would be a good idea. And in this case, steroids help with that. But also in the pulmonary circulation, they seem to induce the activity of phosphodiesterase 5, which helps to increase the vasodilatory activity in the pulmonary circulation, and therefore improves their pulmonary blood flow and drop in the pulmonary pressures, on top of preventing oxidative injury to the pulmonary vasculature, which drives PPHN. Those seems to be some of the mechanisms, but probably others are not yet known at this point. So thank you very much, Dr. Lukia, for taking us through this. And I would like to apologize. Our final speaker of the day had recorded a talk, but we may not be able to project this evening because of some technicalities. So currently, for now, I would like us to welcome our next speaker, Dr. Helen Chokutamba, again, a remarkable lady, and I know. Personally, she's an associate consultant in pediatrics and neonatology at Mulago, specialized women's and neonatal hospital. My God, it's a mouthful. And I hope one day they'll have a shorter version because even the abbreviation is complex. But more importantly also, she's a fellow in neonatology at Macquarie University College of Health Sciences. She'll be taking us through respiratory distress syndrome, a syndrome that bothers many babies and definitely messes up so much in terms of the care. So Dr. Helen, kindly share your slides. Dr. Helen in?
Yes.
Yes, kindly share your slides and start right away. Thank you.
All see the slides. Good evening to you all.
Yes.
Helen, and I'll be taking you through this discussion, very important discussion of respiratory distress syndrome in neonates. Okay. So briefly look at the introduction, lung development and pathophysiology to understand a little more about it, then how it manifests clinically and how we manage it. Yes, formerly it was called hyaline membrane disease, and in some cases it's still called hyaline membrane disease. It occurs when we have incompletely developed lungs, and these lungs usually are deficient of mature surfactant. However, sometimes we may have, usually it presents in the preterm babies, but sometimes we may have it presenting in the full-term babies. The risk decreases with the increasing gestational age, and it's, like I said, 60% when the babies are 28 weeks, and by the time babies who are above 34 weeks, the risk reduces to less than 5%. So we still can get it in the late preterms and in the term babies. So there are factors that predispose these term babies to hyaline membrane disease, and some of them are like when babies have meconium aspiration, like Dr. Daniel talked about previously, when babies have neonatal pneumonia, or sometimes even these babies may have genetic disorders that affect surfactant maturation. So it is very rare, up to like 0.1% in the term babies. Antenatal steroids and prolonged rupture of membranes have been shown to actually reduce the risk of RDS in babies. So RDS has evolved, the management has greatly evolved over time, and we are seeing improved survival with the new therapies that we shall be talking about later. So in the most recent years, the mortality has gone to even less than 10% because of the evolving therapies that are coming up. So there are multiple risk factors for RDS. Specifically, if we talk about risk factors, we want to talk about maternal and infant factors. Multiple pregnancies, elective C-section, gestational diabetes, and I think all this had been talked about before, puts babies at risk of RDS. But the other infant factors, prematurity, of course, is the biggest risk factor. Then the male gender, there's a familial predisposition, there's hypothermia, makes these babies at more risk of getting severe RDS. Babies have asphyxia intrapartum. When they have pulmonary infections, because pulmonary hemorrhage also inactivates the surfactant, meconium aspiration also inactivates the surfactant. Congenital diaphragmatic hernia and pulmonary hypoplasia also may present with surfactant, which is not sufficient enough to prevent RDS. So what exactly is, to talk about RDS, because we need to understand the lung development. And this diagram summarizes the lung development, and it's important to understand it because we are able to know at what period we are able to have our babies viable. And we know in the developed world, they've had even babies as young as 22 weeks actually survive. So the period of viability begins around 23 weeks when the fetal lung begins to transition from the canalicular to the circular stage of development. It's because at this circular stage, the airways enlarge and the distal airways begin to dilate and the walls begin to thin, while the type 2 pneumocytes start also to mature and produce surfactant. So, however, although gas exchange is possible during this stage, total surface area for the gas exchange is not good enough, and the optimal time for gas exchange comes in during the alveolar stage of development, which usually will begin at around 32 weeks gestation. And this is when you have the alveolar walls thinning, all the cell types proliferate, and the type 2 pneumocytes are able to produce and mature enough surfactant for proper gas exchange. So what exactly happens when we have RDS? When we have RDS, these babies, like we said, do not have sufficient surfactant, which is mature. What is the use of surfactant? Surfactant helps to reduce the surface tension and prevent alveolar collapse. So when we do not have enough surfactant, you have an increase in the surface tension and the alveolar will collapse. And when that happens, the babies will need more work of breathing, then there'll be intrapulmonary shunting, then they'll have ventilation perfusion mismatch, hypoxia, and then eventually we get respiratory failure. So the hallmark of the pathophysiology of RDS is about having diminished surfactant in these babies. And the factors, like we said, all these factors will actually lead to reduced surfactant. And then we have progressive atelectasis, like we said, the airways keep collapsing. And then we have hypoventilation. And then we have all these other factors also which will contribute. When we have hypoventilation, that increases the partial pressure of carbon dioxide and reduces the partial pressure of oxygen and reduces the pH. But there are other factors which come into play to worsen the condition, and that's how these worsen the clinical picture of RDS. When you have transient tachypnea in the newborn, when you have asphyxia, hypothermia, apnea, all these worsen the acidosis. And when we have acidosis, then the baby gets hypotensive, the pulmonary vasculature constricts, and then it becomes a cycle because we have impaired also perfusion of the alveoli, and that further even diminishes the surfactant. So when all that happens, when we have impaired endothelial and epithelial integrity with the pulmonary vasoconstriction and all that is happening with the acidosis, then we have a proteinaceous exudate. And that exudate is what actually comprises of the hyaline membrane. And that's why it was initially called hyaline membrane disease. And that's how we get into RDS. But of course, there is also the chronic arm of the RDS, where we eventually end up with cytokines and free radicals that cause further lung injury, and this put the babies at chronic lung disease risk later in life. So this picture just shows the exudates that we've been talking about that tend to occur when we have RDS in our babies. And this diagram represents the physiology that we've been saying, that when we have RDS, the HMD, we have atelectasis, and when we have atelectasis, of course, we will need more pressure to increase the volume. So as the baby breathes, they have to work harder because they have to use more, they require more pressure to actually be able to expand the lungs. And that's how the babies present with all the clinical features of respiratory distress, because there's atelectasis, there are exudates, and the babies have to work so hard to be able to actually expand the lungs and let in oxygen. So how do we diagnose RDS? We diagnose RDS. First of all, the clinical picture is very important. We need to take history, the risk factors. The most important, the first question we always ask is the gestational age, but also we take history of other factors that we've talked about. And then, of course, then we examine these babies for respiratory distress, the signs of respiratory distress, the chest indrawing, the tachypnea, the nasal flaring, the grunt, sometimes cyanosis, and sometimes they may even present with apnea. And we shall see later that in Uganda, in low resource settings, particularly in Uganda also, we use the Silverman-Anderson score, which we shall summarize later how we do it. In the preterm babies, it helps us to assess the severity of RDS and also guide the management of these babies. So sometimes in the extreme preterm babies, you may wait for that severe distress and doesn't come, and the baby just presents with apnea. That may be the only presentation the babies may have with severe RDS. So how do we diagnose it? Investigations, of course, the X-ray has been the gold standard to diagnose RDS. However, there is growing evidence that we should not have to wait for the X-ray before we treat RDS, especially in the preterm babies, because this can sometimes cause delays. And because also we have growing evidence that the point of care ultrasound scan can actually help us to quickly make a diagnosis if we have to make a diagnosis using radiology and be able to manage these babies in time. So when we do our lung ultrasound scan, we're able to see white lungs. Sometimes they have subpleural consolidations, and the A lines disappear, irregular pleural line. Then we can have ground glass opacity sign and snowflake. I didn't go into the details. It's what they also call snowflake signs, that when we look out for these features on the ultrasound, we are able to quickly make a diagnosis and manage, especially if you have late preterms and you want to rule out other possible causes of the respiratory distress in these babies. So lung ultrasound has been shown to be very sensitive, and up to 99% actually, 99 to 100% of sensitivity and specificity of 95 to 99%. So it is a new modality that I think we need to continuously embrace and use to diagnose, make a quick diagnosis of RDS in our babies. So yes, on the X-ray, of course, I didn't talk about X-ray findings. Usually the ground glass appearance is typical, but sometimes you may have air bronchograms that can actually also point to RDS. Like I said, there's growing less emphasis on the radiological diagnosis of RDS before we treat, especially for the preterms, the extreme preterm babies. The other investigations we do, we can do blood gases. Well, we mainly would find the babies to have metabolic and respiratory acidosis and hypoxemia. So this is just an example of the X-rays that we would find in RDS. In the late stages of RDS, when it is severe, the chest tends to be bell-shaped. And as you can see there, there's a ground glass diffuse pattern, and there are air bronchograms when in this severe late stage of RDS. So it's important to know that we can do it, but we do not have to do it, especially when we have those very small ones, because sometimes we need to give immediate early rescue surfactant within the first 2 hours. If we can do it, the better. So these are some of the lung ultrasound scan findings. Well, have a normal lung should look like this, but early stages you will have B lines, then you have white lung, then white lung and fluid alveologram, and then also we have white lung with consolidation. These are the slow flake findings that can be got on lung ultrasound. So that is quickly about the diagnosis. To focus on the management of RDS. RDS management starts even before we deliver the baby, because we need to plan for delivery before we have these babies born. We need to be able to plan well and give the mothers treatment that can reduce the risk of RDS and severity of RDS. So this management approach that I'm going to talk about is from the European Consensus Guidelines of 2023. It is largely what has been used, and I think in most units in this country we follow these guidelines, and our Uganda clinical guidelines also were developed in line with these guidelines. So prenatal care, very important. Like I said, when you have mothers at high risk of preterm delivery, they should be transferred to the centers where they're able to have level 3 care. Now, we should refrain from transporting babies, but transport the mothers with their babies in utero before they are delivered. So these mothers should receive a full course of the prenatal corticosteroids. We use either dexamethasone or betamethasone to help improve the lung maturation. Then magnesium sulfate has been shown to be neuroprotective, and it is also given if there is impending preterm delivery less than 32 weeks. Then tocolytics to delay the delivery so that the babies are able to benefit from steroids have also been shown to be beneficial when we have an impending preterm delivery. So it should usually be a short-term use so that we can able to transfer the baby in utero if the mother needs to be transferred. So in the delivery room, delayed cord clamping is very important. I think we've always, we've always had to always remind the obstetricians, please wait. Usually we want to wait 30 to 60 seconds so that we are able to have enough placenta-fetal transfusion. And this helps us to be able to prevent anemia later, but it also helps to stabilize the babies to prevent hypoxemia within these first few seconds of life as we stabilize the baby. So delayed cord clamp, however, if the baby requires immediate, if the baby is not breathing and requires resuscitation, these babies should be, the cords should be cut and immediate resuscitation done. However, there are even some studies which are showing that providing a resuscitation table next to the mother and starting resuscitation as we wait for the cord, as we wait for 1 minute to cut the cord, in some studies are actually shown to be beneficial for the outcomes of these babies, both respiratory and long-term neurodevelopment outcomes of this baby. So when we have a baby who is born and is spontaneously breathing and is preterm, we immediately start them on CPAP. CPAP should be started in the delivery room as soon as the baby is born and is able to breathe spontaneously. The TPIS CPAP delivery interface has been shown to be good. And there's also a newly designed flow nasal prong CPAP system that has been shown to be very helpful. So sometimes in our settings, when we deliver this baby, immediately we put them on CPAP using our usual nasal prongs. But the TPIS has been shown to offer better outcomes. So usually when the baby is breathing spontaneously, we avoid intubation because this reduces the risk of BPD. So we only intubate if the baby is persistently apneic and is desaturating. And when we do intubate in the delivery room, that's when we have to give surfactant. Surfactant rarely is needed to be given in the delivery room, apart from when we have to intubate. However, there are newer studies also showing that given the LISA method, the less invasive method of surfactant administration, it can be given sometimes, especially in those who are extreme preterm in the delivery room. When we need to resuscitate these babies, we use gentle PPV, usually pressures of 20 to 25, and the PIP, we start with 6 to 8 if the baby is apneic or bradycardic. And like I said, it's always good to use the TPIS contrary to the bag and mask, because you're able to maintain the PEEP when you're using the TPIS vis-a-vis when you're using the bag and mask to resuscitate these babies. Usually with RDS, of course, we expect spontaneous recovery within 48 to 72 hours. However, sometimes it may go on and worsen. Heated, humidified oxygen delivered by high flow nasal cannula versus CPAP. I think there was a question about this in the previous discussion. It's been shown that the CPAP is still the preferred mode of non-invasive respiratory support in these babies, because there's some of the studies have shown that babies who were started on the nasal cannula eventually had to even be put on CPAP to rescue them. So CPAP is still the preferred mode of non-invasive ventilatory support in these babies with RDS. So when we are resuscitating our babies, usually we start with an FiO2 of 30 for those less than 28 weeks, and 21 to 30 for those between 20 to 31, and 21% for 32 weeks gestation and above. However, neonatology is always an evolving field. There's a new study which shows again that the extreme preterm babies can be started on 100% oxygen and gradually reduced. However, we know when we do 100%, there are more risks like retinopathy and other risks that come with 100% oxygen. So for now, we still stick to initial FiO2 of 30 for the preterm babies. Yeah, this is the study that I was talking about where they said we can actually use LISA and start 100% oxygen for the very extreme preterm babies. In the delivery room, very important that we keep our babies hypothermic, because we saw that hypothermia is a very big contributor to worsening RDS in these babies. If the babies are not kept warm, they tend to get more severe RDS. And we use plastic bags or occlusive wrapping, and radiant warmers should be used. We should use humidified heated gas, and we should always aim to have temperature in our delivery rooms to be at least 26. I know we always are flexing for the temperature. Usually when you go to receive a baby who's preterm, you need to take note of the ambient temperature to be at least 26 for those babies who are less than 32 weeks to reduce the risk of hypothermia. So, surfactant. What is surfactant? Surfactant is we said it's what helps us to reduce the surface tension, and it has a mixture of phospholipids and proteins. Phospholipids account to up to 90% and proteins up to 10%. And the most abundant phospholipid is phosphatidylcholine. And the proteins are surface protein A, B, C, and D. B and C have been shown to help more with reducing surface tension and thus reduce RDS. So what do we do? What do we mean by surfactant therapy? This has been a widely researched area, and is always evolving, especially with the different types of surfactant and the means of administration. And currently, what is evidence-based is we should give early rescue surfactants. We still do not have a role for prophylactic surfactant. However, in some settings, I know they still give, and there's some evidence still in some areas that they still give prophylactic surfactant, but the evidence we use is early rescue surfactant. There are three different main types of surfactant. There's the, mainly we have the natural and the artificial surfactant. Then among the natural surfactant, we have the poractant alpha, which is cocaine based. Then we have the beractant, which from bovine. And then we have the bovactant, which is also bovine. Commonly in Uganda, we use Savanta, which is beractant surfactant. However, we are also, there's a new brand which is on board recently, Bovactant, Bless, which will also be seeing along as we manage these babies. So we give early rescue surfactant, and if it's poractant alpha, we give an initial dose of 200 milligrams per kilo. And if you want to reduce the risk of repeated doses. However, when we are using beractant surfactant, we use 100 milligrams per kilo. And if we assess babies and see if they need, sometimes we may need to give them repeated doses depending on the clinical response. So usually when do we give surfactant? Now, when do we give surfactant? That answer, there's what is evidence-based is in some settings they use they give surfactant when the FiO2 requirement of these babies already on CPAP was above 30%. However, in some settings, they consider 40 or 50%, but from these guidelines that most of the protocols are derived and where the evidence is from, we use a FiO2 of 30%. And we use a CPAP. We start with, usually these babies will have been on CPAP of at least 6 centimeters of water. And also if we have a lung ultrasound scan, which is suggestive of RDS, ideally we give these babies surfactant immediately. So meaning so many of our babies that we take care of actually would be eligible for surfactant. However, in our low resource settings, there's the Silverman-Anderson score. Maybe at this point I should. The Silverman-Anderson score is what we use when we are not able to get oxygen blenders to assess severity of respiratory distress. And we give it when we have a SAS score of 6 or more. And I'll not go into the detail, but we look at how the chest is moving, the upper chest, the lower chest, the xiphoid retractions, the nasal flaring, and the expiratory grunt. And then it's graded 1, 0, 1, 2. So and then we add what we get in each of these different parameters. And then this helps us to know the severity of respiratory distress. So in our setting, when we have a baby who has a SAS score of 6 or more, that baby, we give surfactant. However, we've seen sometimes, like we've said, in the extreme preterm babies, sometimes they may not even necessarily have respiratory distress, which is visible, and you just see them getting apneic. So it also has its limitations, but currently that's what we use. But in settings where we're able to get oxygen blenders, we use the FiO2 requirement for these babies when they're already on CPAP. And LISA has been shown to be the most preferred means of administrating surfactant. LISA is less invasive surfactant administration. It has been shown to reduce the risk of complications like BPD, intracranial hemorrhage in these babies, and also reduce the risk of mechanical ventilation, because you have less injury to the alveoli. Because in this method, we just use a catheter and under direct laryngoscopy, insert it into the trachea and administer surfactant while the baby is still on CPAP. And then we withdraw the catheter after instilling the surfactant and leave the baby on CPAP. So this means we do not have to do positive pressure ventilation, and this is why it has been shown to be safe and reduce the risks of complications. Laryngeal masks have been also explored, and for babies who are less than 1 kilogram, they've been shown to be a good alternative for surfactant administration, where we don't want to be invasive in our babies. There is also what we call ensure, where we intubate and administer surfactant and extubate. It is the other method which is still largely used here in our settings. It also reduces the risks, but the most superior way would be the LISA. So we monitor for second and third dose if needed, and we give, and we avoid invasive mechanical ventilation where possible, because this is where usually when we ventilate these babies, it is very hard to, weaning them off is another process, and the less we ventilate them, the better, to reduce the long-term effects on these babies. I think this still, there are still other ways of administering surfactant which are being explored and researched. However, we don't yet have enough evidence for them, like nebulized surfactant. I think the new surfactant which they are bringing on board, there's a question about whether we can nebulize it and use it in our babies. Use of laryngeal masks we've talked about, but I think there's more evidence for use of laryngeal masks in babies who are more than 1 kilo, and they can be used. Then there's also where we can actually just deposit it at the larynx at birth without having to use a laryngoscope. However, the benefits have not been shown to be promising. There's also where we administer surfactant with budesonide to reduce the risk of BPD, use of surfactant with inhaled nitric oxide to manage PPHN. All these are different ways of administering surfactant which are under which are being investigated. But currently we use the LISA and ENSURE method. And if the baby is apneic, of course, we would have to intubate and give surfactant and ventilate. But there's also more evidence for the laryngeal masks. So how do we give oxygen? Of course, after stabilizing, like we said, we need to target our oxygen saturation to be between 90 and 94. And we've seen that there are studies which show that we don't have to achieve 100% saturations to reduce the risk of ROP. We need to minimize and target our FiO2s so that we're able to get optimum oxygen saturations without putting these babies at more severe complications later in life. The non-invasive respiratory support, I've been talking about CPAP. It improves oxygenation, regulates the breathing, and it helps in reducing the risk of re-intubation after extubation. And it is still the preferred over the high-flow nasal cannula. And it provides several benefits, like it splints the airway, maintains the lung expansion, prevents the end expiratory alveolar collapse. And bubble CPAP has been shown to be good. However, there is also the flow driver CPAP that has a theoretical advantage of offloading respiratory work of breathing. However, bubble CPAP has been shown to be very useful and beneficial in our babies. There are different interfaces of providing CPAP. We can either use nasal prongs or masks, but there's been shown no difference in the good outcomes between the two, so we can use any of them. And when we are weaning off CPAP, we gradually reduce. We don't just say we are going to change from CPAP to free flow oxygen. We gradually reduce the PEEP, and this helps us to be able to quickly wean off the babies, because sometimes there's a high risk of, it's been shown that there's a high risk of failure if we wean these babies off CPAP suddenly. So generally, CPAP with early rescue surfactant is the optimal management of babies with RDS. Why we say early rescue? Because you don't want to be using laryngoscopes on all the most preterm babies when it's not indicated. So we need to look out for oxygen blenders and be able to monitor the FiO2 requirement, and where possible, when we can do the point of care ultrasound scan, we need to do the bedside ultrasound scans for evidence of RDS. And where we are not able to do that, we use the Silverman-Anderson score, and this has also been shown to help in the low resource settings. There are other modalities of non-ventilatory support. There is the bi-level CPAP or the BiPAP. It is a variant of CPAP that uses small pressure differences in the inspiratory and expiratory phase. And there's no evidence that it confers any advantage over the CPAP. Then there is the nasal intermittent positive pressure ventilation. Pressures are similar to those used for the invasive mechanical ventilation. It's an alternative to CPAP when our babies are on ventilation, but it usually requires, it's been shown to reduce the need for reventilation and air leaks, but does not reduce it does not reduce the risk of BPD. So in all this, we still have CPAP, which is widely available, and all this evidence shows that we can still use our CPAP. The only advantage of the high flow nasal cannula is the less trauma during, or to the nasal bridge during the weaning. However, CPAP, all this evidence shows that CPAP is still the optimal way to support our babies in a non-invasive way when they have RDS. So mechanical ventilation, there's still high need for mechanical ventilation in some of our babies. despite giving surfactant and like the first case which was presented, the baby was given surfactant but still required mechanical ventilation. So usually we need it when baby is not improving on CPAP and all the interventions have been put in place, especially for the babies who are less than 28 weeks. So usually we want to provide acceptable blood gases while avoiding lung injury. And we need to inflate the atelectatic lung, optimize lung volume, or even this, we need to avoid overdistension when we are ventilating these babies. So when we overinflate the baby, we get air leaks, and the babies will present as a pneumothorax or pulmonary interstitial emphysema. And when we ventilate at very low pressure, the atelectatic lung will generate inflammation and therefore worsening the clinical condition of the baby. So we need to have optimal pressures that will be able to give us acceptable blood gases for this baby. So there are different modes of ventilation. There's a volume targeted ventilation, which has been shown to be better compared with the time cycled pressure ventilation. Usually it results in less time on the ventilator, and we have fewer air leaks and less risk of BPD. High flow, the HFO, that is high frequency oscillatory ventilation. It allows gas exchange to be delivered using very tiny volumes, and it is the optimum when we have RDS, because this will prevent the injury that would be produced by the high pressures. So there are very fast rates and very small tidal volumes that will hold the lung open, and this is usually using the continuous distending pressure which is generated. So it's been shown to reduce the risk of BPD compared to the conventional mechanical ventilation. So it's the optimal way of managing these babies with RDS, and where available, oscillatory ventilation is the best. So we need to extubate these babies when we ventilate them as soon as possible. And these are the settings that would what would need to look out for before we extubate these babies. I'm not going to the detail. So another way to support this baby, there are different ways to support the baby. Another way is when we give this baby surfactant, it helps to facilitate earlier extubation, because in the CAP trial, it was found that these babies also have a reduced risk of BPD, and they have better neurodevelopmental outcomes. And there's growing evidence that the earlier caffeine is given, the better for the babies. And inhaled budesonide also has been shown to reduce risk of PDA and BPD. All these are different modalities of managing the babies and supporting them. So, but some of these trials are not yet conclusive, and we don't yet have a sample size and enough evidence to implement them, but some of them I know in some centers are actually implemented. Dexamethasone, of course, to facilitate extubation if the baby has been on mechanical ventilation for more than 1 week. And then the inhaled nitric oxide is usually a trial when there's documented pulmonary hypertension, especially when there is severe respiratory distress, and usually you'd want to stop it within a short time, because sometimes it also puts the babies at more complications. Importantly, in our babies, these preterm babies, we do not routinely use morphine or midazolam, because we do not want to sedate these babies, because we're aiming at extubating them at the earliest possible time. So routine use of midazolam and midazolam infusions in the ventilated preterm babies is not recommended, and there's evidence for that. Other supportive care, post maintaining temperature in the right ranges at all the times, fluids, depending on the losses and the clinical condition of the baby. Parenteral nutrition, someone was asking about milk. We need to start milk on the first day if it is available and if the baby has stabilized. We treat hypotension, anemia, and look out for, they tend to present also with a hemodynamically significant PDA. We manage it. And importantly, in our babies, we start antibiotics until when we have excluded infection, because we know we don't have time to wait, and yet also the infections are some of the risk factors for sepsis. So risk factors for RDS. So we need to start these babies on antibiotics as we wait. Yeah, this is just a short of our guidelines, our Ugandan neonatal guidelines on RDS. I'm not going to the detail, but basically derived from the European consensus guidelines of management of RDS. Just that for us, we use the Silverman-Anderson score to give our babies surfactant. Thank you.
Excellent. Thank you. Thank you very much, Dr. Helen, for this talk. All right, so we would like to open up to questions again. And I think I see just one question right now in the chat. Please send in more questions. So first question is, can you shed more light on why we don't give surfactant beyond 72 hours? Are there cases where this doesn't apply?
Yeah, the natural history of RDS would be that after around 72 hours, there should be recovery starting. Surfactant given after 72 hours, usually you would want to first exclude other causes of the RDS, but also the benefits are not as great as when it is given early. These babies should ideally be, we need to, and it's evidence that we need to be able to monitor and observe these babies and give surfactant within the first 2 hours if they are needed, and usually that is the optimum time. However, between that time of delivery and 72 hours, if we show the need for surfactant, we give it. After 72 hours, the benefit is not as great because by that time we have already the air leaks, atelectasis, though sometimes we give it and then still ventilate the babies. Some of them respond, but it's largely because of the natural history of RDS in these babies. Thank you.
All right, okay, so then there's one more question saying, kindly shed more light on why cesarean section is at risk of RDS. Why elective C-section babies are at high risk of RDS?
With an elective cesarean section, remember these babies are also at risk of transient tachypnea and the fluid reabsorption hasn't optimally taken place. So this will further inactivate the little surfactant, which is even already there. So it's along the fluid within the airways being more when it is an elective cesarean section. Thank you.
All right, thank you very much, Doctor. So I don't know, there were some, do you have any comments on the previous topics maybe that were asked, that were presented also by Dr. Luquia? There's some questions there regarding things like PHN, and the use of steroids, TTN, and I believe something, I don't remember exactly the specific one, I'll look it up. Do you have any comments regarding those two areas?
Yeah. PPHN, yes. PPHN, steroids do not necessarily have a role in management of PPHN. I've not seen evidence for that, and I don't think it's that. However, the steroids usually we give, like Dr. Daniel talked about, usually we are worried about or usually our babies will get hypotension. However, it is always the optimal care would be to first monitor the baby for hypotension. Not every baby who is on vasodilators should immediately be started on steroids. We need to start on steroids when we have evidence of hypotension to manage the hypotension. Then there was a question about diabetic mothers and the risk for RDS and TTN. Usually the babies who are born, infants of diabetic mothers, tend to have high insulin levels, and the high insulin levels impaired, they affect the maturation and production of surfactants. So these babies are at more risk of RDS and TTN because of the high insulin levels. Which other question?
Yeah, there was a question on which mechanical ventilation modality you would prefer in children with the mass in terms of volumes, high volume ventilation, low tidal volume ventilation, let's say about 64 to 6 or something like that.
Yeah, meconium aspiration syndrome, similar to respiratory distress syndrome, there's a high risk of air leak, and the optimum way of ventilating these babies is using the high frequency oscillatory ventilation where possible. It's just like RDS.
All right. Okay. So, and then I think the final question I'm seeing on the chat is, at what gestational age is surfactant not given?
That's an interesting question, because usually we see sometimes surfactant being given based on gestational age. However, there is no evidence that we need to give surfactant at a specific gestational age, because we've seen babies as big as 36 weeks with worse RDS than those that are 26 weeks. So there's no, even sometimes we actually give surfactant to term babies. So there's no gestational age beyond which we can say we don't need surfactant, or below which we say we must give surfactant. We need to have the evidence for RDS where possible. But in the very small ones, if they have the babies who are less than 28 weeks and they have respiratory distress, and you have an increasing FiO2 requirement, or you have a SAS score which is high, we give surfactant. So we've had very many babies who are 26 weekers and they have passed through the neonatal unit and they never got surfactant. So it is largely based on other parameters, not gestational age. Thank you.
Excellent, excellent. Thank you very much, Dr. Helen. Again, this is really where it all starts, babies. And we have all been babies before. I know most of you don't remember that part because, I mean, you are not thinking at that stage. Shame. But this is a beautiful expose to what we all went through. Of course, hopefully not all of us had to endure such illnesses, but this is how our physiology has evolved. And now that we are practicing doctors, it's important to understand where we came from. So this has been a beautiful session. Unfortunately, we're supposed to have our next talk given by Dr. Victoria Nashibuka, but because we're short of time, but even more importantly, there was some technical issue with the presentation that she sent to us. We will not be having that talk. And so we will be concluding this conversation this evening. So I'd like to thank our presenters for today, Dr. Winnie for the cases, Dr. Lupia for the talk on PPHN, TTN, and MAS, and then Dr. Helen Jokutamba for sparing time to discuss with us on RDS. There's a lot more to talk about regarding these babies, and otherwise, you know, we cannot cover all of it in one session. So thanks to you, Pulmonary Madness has been possible, and this topic on back the Cradle has been possible. So some quick take home before we conclude is that babies are surely not small adults. And for many of you who thought that the physiology of a baby is merely a few fractions smaller than that of an adult, wake up. It is extremely complex, extremely interesting, and extremely basic science. And it's quite fun to listen to these doctors go through what they do and the scientific basis of everything. These babies have immature lungs that are still, some of which are still maturing. Some probably have been terminated in terms of maturation due to early birth for so many different reasons. And some may be altered by disease that leads them to premature delivery. So the immunity is weaker, so they're not exactly like the rest of the patients. Therefore, they require a little bit more, more nuanced care. And there's influence of the mother on that baby through that cord, even after the baby is born, in terms of the antibodies, in terms of the nutrients, some of the hormones have been exchanged between the baby and the mother. There's always a broad differential to respiratory distress in babies, including congenital causes that need to be considered, especially when you receive them getting sick in the first few hours of their lives. But certainly PHN, TTN, and MAS can be so disturbing. RDS is so annoying, especially for a worker who works quite away from where mechanical ventilator support can be available, because some of the children can really get sick. And yet somehow with just the basics of support, they get better quite quickly. So hopefully that should encourage all of us to aspire to, to give these children the very best possible care. Unique treatment approaches exist for the different unique neonatal challenges, but time is of the essence, because whereas these babies have a profound physiological reserve, it also decays quite quickly in time where not supported. And knowing your physiology is extremely, extremely key. This has been quite a lovely session, and I would like to thank you guys for holding on up to now. So next week, we switch back to the fun things that make critical care such a dear subject to some of us, just to see how organs interact. So we shall be dealing with a multi-organ higi-haga, just to understand how different organs interact with the lung, how they can affect the lung, and how the lung can affect them. It's going to be fun. So tell a colleague, to tell a colleague, to tell a colleague to join us on the day. So thank you for today, and bye-bye. Happy weekend. Welcome to March. Bye-bye.